Abdul Manaf, penolong rektor kampus Sungai Buloh, Selayang dan Teluk Intan diiringi oleh dekan dan pengurusan tertinggi Fakulti Pergigian masuk ke dalam Dewan. Para hadirin dimohon berdiri. Bagi nyanyian lagu Negaraku dan Wawasan Setia Warga UiTM.
Bersatu kita warga UiTM, kita bangsa perkasa, taat dan setiaku untuk negara, penuh semangat wajar. Kita jangan mudah terlupa pengorbanan perjuangan anak bangsa.
Para hadirin dipersilakan duduk. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera dan salam Malaysia Madani. Yang berusaha Profesor Madya Dr. Muhammad Hezir Abdul Manaf, penolong rektor kampus Sungai Buloh, Selayang dan Teluk Intan UiTM Cawangan Selangor. Yang diraikan Profesor Dr. Rohana Ahmad. Yang berusaha Profesor Madya Dr. Mas Suryalis Ahmad, Dekan Fakulti Pergigian UiTM. Yang berusaha Profesor Madya Dr. Siti Mariam Nabugani, Timbalan Dekan Akademik dan Antarabangsa Fakulti Pergigian UiTM. Yang berusaha Profesor Madya Dr. Budi Asrini Mat Sabri, Timbalan Dekan Penyelidikan dan Jaringan Industri Fakulti Pergigian UiTM. Yang berusaha Dr. Melati Mahmud, Pengarah Program Majlis Syarahan Profesor Fakulti Pergigian UiTM. Yang berusaha Profesor-Profesor, Timbalan-Timbalan Dekan, Ketua-Ketua Pusat Pengajian, Barisan Jawatankuasa Majlis Syarahan Profesor Dr. Rohana Ahmad, para pensyarah, tuan-tuan, puan-puan yang dihormati sekalian serta para pelajar sekalian. Selamat datang ke Majlis Syarahan Profesor UiTM, Profesor Dr. Rohana Ahmad. Alhamdulillah, bersyukur kita kehadrat Ilahi kerana dengan limpah kurnia dan izinnya dapat kita berkumpul di dalam majlis yang gilang gemilang pada pagi ini. Hadirin sekalian, bagi memohon keberkatan majlis dengan hormatnya mempersilakan Ustaz Muhammad Najih Irsyad Ahmad Puhad untuk memimpin bacaan doa. Dipersilakan.
Al-Fatihah. Bismillahirrahmanirrahim. Alhamdulillahilladzi ja'ala awwala yawmina hadha salaha wa awsatahu falaha wa akhirahu najaha. Wassalatu wassalamu ala ashrafil mustafa Sayyidina Muhammad wa ala alihi wa sahbihi wa man ihtada. Allahumma ya Rahman ya Rahim. Ya Allah ya Tuhan kami bersyukur kepadamu dengan izin-Mu jua kami dapat berkumpul pada hari ini. Oleh itu Engkau jadikanlah hari ini lebih baik bagi kami dari hari-hari yang telah lalu. Akidah kami semakin kukuh, ibadah kami semakin bertambah, akhlak kami semakin cemerlang, rezeki kami semakin luas dan halal, umur kami umur yang diberkati, dan amal kami amal yang diridai. Allahumma ya Aziz ya Jabbar. Sempena dengan majlis syarahan Profesor Dr. Rohana Ahmad ini juga kami memohon kehadrat-Mu ya Allah. Engkau berkatilah majlis ini. Engkau rahmatilah sekalian yang hadir di dalam majlis ini. Jadikanlah segala usaha dan amal kami sebagai amal yang Engkau redai. Ilhamkanlah dalam fikiran kami idea-idea yang bernas, kreatif, kritis, positif, mantap dan berpandangan jauh. Allahumma ya Rahmanu ya Rahim. Kurniakanlah kepada kami sifat kesungguhan dan ketekunan pada diri kami untuk merangka strategi bagi mencapai kecemerlangan serta matlamat wawasan sebagaimana yang dicita-citakan. Mudah-mudahan dengan usaha sebegini akan menjadikan kami insan yang cemerlang di dunia dan di akhirat. Allahumma ya mujibas sa'ilin. Lindungilah negara kami yang dicintai ini dari segala ancaman dan mara bahaya, agar kami dapat hidup dalam aman merdeka. Hindarilah kami dari bala bencana dan wabak penyakit. Jauhilah kami dari segala perpecahan, perselisihan, pertengkaran dan kemungkaran yang membinasakan. Allahumma ja'al jam'ana hadha jam'an marhuma wa tafarruqana min ba'dihi tafarruqan ma'suma wa la taj'al fina wa la ma'ana syaqiyan wa la matrudan wa la mahruma. Wa sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi wa baraka wa sallam. Walhamdulillahi Rabbil Alamin.
Majlis merakamkan ucapan terima kasih kepada Ustaz Muhammad Najih Irsyad Ahmad Puhad atas pimpinan bacaan doa sebentar tadi. Hadirin yang dihormati sekalian, program syarahan utama profesor di setiap fakulti di UiTM merupakan salah satu medan pengiktirafan kepada profesor tersohor pada jasa bakti dan kerjaya mereka sepanjang di universiti. Program ini akan menjadi platform dan memberi ruang kepada para profesor untuk berkongsi kajian terkini, pandangan dan kewibawaan mereka dalam bidang kepakaran masing-masing. Kepakaran meliputi penyelidikan asal dan pengajaran peringkat kursus-kursus mahasiswa, profesional dan lepasan ijazah dalam bidang kepakaran. Program syarahan utama profesor ini merupakan peluang terbaik untuk memperkenalkan profesor daripada Fakulti Pergigian UiTM kepada pihak dalam dan luar fakulti, khususnya kepada para akademik, pelajar pasca siswazah dan institusi pengajian tinggi yang lain. Program ini juga secara tidak langsung dapat menyebar luas kepakaran dan ilmu pengetahuan serta penemuan inovatif oleh profesor universiti ini. Ilmu pengetahuan yang dikongsi melalui syarahan utama ini adalah sebahagian dari inisiatif Fakulti Pergigian UiTM untuk mengetengahkan kesarjanaan dan ketokohan para akademiknya kepada pemegang taruh yang terdiri daripada badan-badan profesional, pihak industri dan agensi berkaitan dalam bidang pergigian. Melalui program syarahan utama ini, Profesor Dr. Rohana Ahmad akan berkongsi ilmu hasil dari penyelidikan beliau tentang rawatan pergigian di dalam bidang implan prostodontik. Buku hasil tulisan beliau yang bertajuk Bone Remodeling Dynamics in Implant Integrated Dental Prosthesis akan memberikan input dan perbandingan beberapa analisa berkaitan dengan rawatan prostetik implan dan kesannya kepada proses pemodelan tulang. Tuan-tuan, puan-puan dan hadirin sekalian, bagi meneruskan acara pada pagi ini, Majlis menjemput Yang Berusaha Profesor Madya Dr. Mas Suryalis Ahmad, Dekan Fakulti Pergigian UiTM untuk menyampaikan ucapan aluan dengan segala hormatnya di
Terima kasih pengacara majlis. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam Malaysia Madani dan salam UiTM di hatiku. Yang Berusaha Profesor Madya Dr. Muhammad Haizir Abdul Manaf, Penolong Rektor Kampus Sungai Buloh, Selayang dan Teluk Intan UiTM Cawangan Selangor. Yang diraikan Profesor Dr. Rohana Ahmad, Profesor Fakulti Pergigian UiTM. Yang Berusaha Profesor Madya Dr. Siti Mariam Abdul Ghani, Timbalan Dekan Akademik dan Antarabangsa Fakulti Pergigian UiTM. Yang Berusaha Profesor Madya Dr. Budi Aslini Mat Sabri, Timbalan Dekan Penyelidikan dan Jaringan Industri Fakulti Pergigian UiTM. Yang Berusaha Dr. Melati Mahmud, Pengarah Program Majlis Syarahan Profesor Fakulti Pergigian UiTM. Yang Berusaha Profesor-Profesor UiTM, Timbalan-Timbalan Dekan, Ketua-Ketua Pusat Pengajian, Barisan Jawatan Kuasa Majlis Syarahan Profesor Dr. Rohana Ahmad, tuan-tuan dan puan-puan yang dihormati serta para pelajar sekalian. Alhamdulillah, dengan limpah kurnia dan rahmatnya, kita semua diberikan kesempatan untuk berhimpun dalam majlis yang penuh bermakna ini. Adalah satu penghormatan buat saya berdiri di hadapan hadirin sekalian bagi meraihkan kejayaan besar dalam perjalanan akademik seorang tokoh yang amat dihormati di Fakulti Pergigian, iaitu Profesor Dr. Rohana Ahmad. Hari ini kita bukan sahaja berasa bertuah, malah berbangga kerana diberi peluang untuk mendengar syarahan beliau yang merupakan satu pengiktirafan terhadap sumbangan luar biasa yang telah beliau curahkan kepada institusi ini serta komuniti secara keseluruhannya. Perjalanan akademik Profesor Dr. Rohana adalah bukti bahawa kehausan terhadap ilmu disertai dengan semangat yang tidak pernah pudar dan komitmen yang teguh mampu membawa kepada kejayaan yang cemerlang. Kepakaran beliau dalam bidang penyelidikan, pedagogi serta kerjasama profesional bukan sahaja menyemarakkan lagi pemahaman kita terhadap bidang pergigian, malah membantu dalam mengasimilasikan amalan pergigian kontemporari serta memperkasakan penyelidikan berimpak tinggi demi pembangunan fakulti pergigian khususnya dan UiTM amnya. Dalam era di mana inovasi menjadi pemangkin kepada kemajuan dalam bidang pergigian, Profesor Dr. Rohana terus menunjukkan dedikasi serta komitmen yang tidak berbelah bagi. Keazaman beliau dalam menuntut ilmu dan menyumbang kepada kemajuan akademik menjadi sumber inspirasi buat kita semua untuk terus berusaha mencapai kecemerlangan. Mewakili Fakulti Pergigian Universiti Teknologi Mara, saya ingin merakamkan ucapan setinggi-tinggi tahniah kepada Profesor Dr. Rohana Ahmad atas pengiktirafan yang berprestij ini. Semoga pencapaian luar biasa beliau menjadi dorongan buat kita semua untuk terus maju dalam bidang akademik, penyelidikan dan inovasi pada masa hadapan insya-Allah. Hari ini bukan sahaja meraihkan kejayaan Profesor Dr. Rohana, tetapi juga detik penting untuk kita menjadikannya sebagai inspirasi dalam menyuburkan budaya kecemerlangan dan cita-cita tinggi. Tanpa melengahkan masa, marilah kita sama-sama mendengar perkongsian ilmu dan pencapaian Profesor Dr. Rohana Ahmad. Sekian, wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Majlis merakamkan ucapan terima kasih kepada Yang Berusaha Profesor Madya Dekan Fakulti Pergigian UiTM atas ucapan aluan sebentar tadi. Majlis diteruskan lagi dengan bacaan ucap jasa Yang Berusaha Profesor Dr. Rohana Ahmad oleh Yang Berusaha Profesor Madya Dr. Budi Aslini Mat Sabri, Timbalan Dekan Penyelidikan dan Jaringan Industri Fakulti Pergigian UiTM. Majlis dengan segala hormatnya mempersilakan.
Assalamualaikum. Good morning, esteemed guests, respected colleagues, distinguished professors, lecturers, postgraduate and undergraduate students. It is my distinct honor and privilege to introduce to you our keynote speaker for today, Professor Dr. Rohana Ahmad. Professor Rohana Ahmad is a distinguished academic, researcher, and clinician in the field of prosthodontics with a specialization in implant dentistry. Her research endeavors focus primarily on the biomechanics of implant-integrated prosthesis, implant materials, surface characteristics, and mechanobiology associated with implant-induced bone remodeling. Today's lecture, titled Bone Remodeling Dynamics in Implant-Integrated Dental Prosthesis, will shed light on the innovative work that has positioned her as a leader in this field. Professor Rohana embarked on her academic journey with a Bachelor of Dental Surgery from the University of Manchester, United Kingdom in 1993. Her quest for knowledge took her across continents, where she earned a Master of Science and a certificate in prosthodontics from Boston University, USA in 1999. Her relentless pursuit of academic excellence culminated in her PhD from the University of Sydney, Australia in 2012, where she delved into the biomechanical intricacies of oral mucosa and bone remodeling. Her doctoral research provided groundbreaking insights into the bone remodeling dynamics associated with implant retained overdentures. Her academic career began as a tutor at the Faculty of Dentistry, University of Malaya in 1994, where she later served as a lecturer and subsequently as a senior lecturer in the Department of Conservative Dentistry. In 2006, she joined University Technology Mara, UiTM, as an associate professor at the Center of Study for Restorative Dentistry. She was one of the pioneer faculty members and was instrumental in designing the faculty curriculum, setting up the simulation laboratory, the clinical and research facilities. She had served as the Deputy Dean for Academic, Research, as well as for Student Affairs. Professor Rohana is not only a dedicated educator, but also a respected postgraduate supervisor. Over the years, she has successfully guided numerous students to the completion of their master's, doctoral, and clinical doctorate degrees, fostering a new generation of dental professionals and researchers. Her current supervision portfolio includes MSc, PhD, and declined candidates working on topics ranging from implant biomechanics to salivary biomarkers for bone remodeling. Her contributions to the field of prosthodontics are noteworthy, with numerous publications, primarily in high-impact journals, reflecting the significance and quality of her research output. Her research has garnered national and international recognition, including awards for innovative work in implant materials, such as the Gold Award from Pechipta, IENA Germany, and ITEX for her research on porous nickel titanium dental implant, which is a collaborative work with Nitium Technology Sdn Bhd and the College of Engineering UITM. Together, they hold multiple patents. Professor Rohana's research portfolio is notable, with numerous grants secured from prestigious bodies, including the Ministry of Science, Technology and Innovation Malaysia, or MOSTI, from the Ministry of Higher Education, and international collaborations such as the Australia-Malaysia Institute. Her work on bone remodeling associated with implant overdentures has provided invaluable insights into the dynamics of residual ridge resorption and the structural optimization of implant prosthesis. Beyond her research and teaching commitments, Professor Rohana has held several key administrative positions, including that of the Deputy Director of the Health and Wellness Research Nexus at UITM, the Deputy Dean for Academic, Deputy Dean for Research, Industrial Linkages, Alumni and Networking, and as members of various national and international research committees. She is also the current Chief Editor of the faculty's academic journal, which is the Compendium of Oral Science, contributing to the scholarly discourse in dentistry. Her role as a grant assessor for national and international funding bodies highlights her standing in the research community. Her dedication to the profession extends to her active involvement in professional associations. She has served as the president of the International Association for Dental Research, IADR Malaysian section, and as a vice president of the Malaysian Association of Prosthodontics. She remains as an active member of the International Society for Maxillofacial Rehabilitation and the International College of Prosthodontics. Her contributions to the development of postgraduate prosthodontic curricula and her involvement in the Malaysian Conjoint Board for Prosthodontics further underline her commitment to advancing dental education. In addition to her academic and research achievements, Professor Rohana has shared her expertise at numerous conferences worldwide, including keynote addresses at the International Association for Dental Research, the Malaysia Association of Prosthodontics, and other esteemed platforms. Her insights into the interaction of mechanical forces with biological responses in implant prosthesis has significantly influenced both clinical practice and academic discourse. On a more personal note, Professor Rohana is known for her genuine passion for teaching, her meticulous approach to research, and her unwavering commitment to patient care. She is admired by her colleagues and students for her approachable demeanor and dedication to advancing dental education and clinical practice. Her hobbies include swimming, spending time on social media, and not forgetting online shopping, offers a glimpse into the person behind the academic persona. Ladies and gentlemen, it is indeed a privilege to have with us today such an accomplished and inspiring individual. So without further ado, please join me in welcoming Professor Dr. Rohana Ahmad to deliver her professorial lecture titled Bone Remodeling Dynamics in Implant Integrated Dental Prosthesis. Thank you. Oh, okay, I think there's the one touch first.
Terima kasih diucapkan kepada Yang Berusaha Profesor Madya Dr. Budi Aslini atas bacaan ucap jasa sebentar tadi. Hadirin sekalian, sekarang marilah kita saksikan sebuah tayangan montaj yang telah disediakan.
Assalamualaikum warahmatullahi wabarakatuh. And hi, I'm Dr. Zati Hanum binti Muhammad Kasim, a lecturer from the Restorative Department UiTM. I've known Prof. Rana for over 20 years. Prof has been a very kind and encouraging educator. She's also a very talented researcher who has published high-impact research work. I would like to congratulate Prof on her professorial talk, and I wish her all the best for her future endeavors.
Prof. Rohana being the first few academic staff who were involved in setting up Faculty of Dentistry at the initial planning brings all the advanced prosthodontics equipment and putting the ground very well for the prosthodisciplines. For that, we were very grateful, and we are also fortunate to have her as one of the senior members in the department where we always go to seek for advices and opinion. Thank you, Prof.
Hadirin sekalian, untuk makluman para hadirin, Majlis Syarahan Profesor UiTM Profesor Dr. Rohana Ahmad pada hari ini dipancarkan secara langsung melalui siaran langsung UiTM Channel, melalui siaran YouTube. Kini tibalah acara kemuncak yang dinanti-nantikan. Dengan ini, Majlis menjemput Profesor Dr. Rohana Ahmad untuk naik ke pentas bagi menyampaikan syarahannya yang bertajuk Bone Remodeling Dynamics in Implants Integrated Dental Prosthesis. Dengan segala hormatnya, dipersilakan
Bismillahirrahmanirrahim. Yang berusaha Profesor Madya Dr. Muhammad Haizir Abdul Manaf, Penolong Rektor Kampus Sungai Buloh Selayang Dental Intan, UiTM Cawangan Selangor. Yang berusaha Profesor Madya Dr. Masur Alis Ahmad, Dekan Fakulti Pergigian UiTM. Yang berusaha Profesor Dr. Titi Ningsih Muhammad Dom, Dekan Fakulti Pergigian Universiti Kebangsaan Malaysia. Yang berusaha Profesor Madya Dr. Siti Mariam Abdul Ghani, Timbalan Dekan Akademik dan Antarabangsa, Fakulti Pergigian UiTM. Yang berusaha Profesor Madya Profesor Madya Dr. Budi Aslini Mat Sabri, Timbalan Dekan Penyelidikan dan Jaringan Industri, Fakulti Pergigian UiTM. Yang berusaha rakan-rakan profesor dari UiTM yang sudah hadir, Timbalan-timbalan dekan, ketua-ketua pusat pengajian, para pensyarah, tetamu jemputan dari Fakulti Pergigian Universiti Kebangsaan Malaysia, Profesor Madya Dr. Badia Baharin, Timbalan Akademik Fakulti Pergigian UKM, Profesor Madya Dr. Jasmina Kamaruzaman, yang juga the past president of the International Association for Dental Research Malaysian Section. Thank you for coming. Rakan industri dari Nitim Teknologi Sdn Bhd, barisan jawatan kuasa Majlis Syarahan Profesor yang dipengerusikan oleh Dr. Melati Mahmud, staf-staf pentadbiran dan klinikal, para pelajar yang dikasihi, dan yang terakhir disebut tetapi paling dekat di hati, ahli keluarga saya yang datang dari dekat dan jauh untuk sama-sama meraihkan hari yang sangat bermakna bagi diri saya. Terima kasih banyak sudi datang. Assalamualaikum warahmatullahi taala wabarakatuh. Salam sejahtera dan salam UiTM di hatiku. Alhamdulillah, setinggi-tinggi kesyukuran saya panjatkan kehadrat Allah Subhanahu Wa Taala kerana dengan limpah rahmat dan kurnianya dapat kita bersama-sama berkumpul pada hari ini dan dalam satu majlis ilmu yang diberkati Allah hendaknya. Terima kasih yang tidak terhingga saya ucapkan di atas kesudian para hadirin sekalian meluangkan masa menghadiri majlis syarahan profesor saya. Saya amat berterima kasih kepada Dekan Fakulti Pergigian, PM Dr. Masrur Halis dan mantan Dekan Profesor Dr. Aida Nur Ashikin serta barisan jawatan kuasa penganjur dan yang dipengerusikan oleh Dr. Melati Mahmud di atas segala usaha yang telah dijalankan untuk menjayakan program ini semenjak bulan Disember tahun lepas. Saya amat terharu di atas penghargaan yang diberikan kepada saya oleh fakulti ini dan kenangan indah ini akan saya simpan hingga ke akhir hayat. Terima kasih juga saya ucapkan kepada rakan industri Nikem Teknologi Seni Yang Berhad dan Stroman di atas sumbangan yang diberikan. Izinkan saya untuk menyampaikan syarahan saya seterusnya dalam bahasa Inggeris. It's a great honor to be standing here this morning to share insights from my work on bone remodeling dynamics in implant integrated dental prosthesis, which I will be focusing on the residual risk resorption associated with a complete denture and implant return of denture for the dentist patient. My research journey in this particular field began with my PhD in 2008 in implant dentistry and bone dynamics, where I conducted a clinical study with a 5-year follow-up to assess implant integrated prosthesis outcome. We then conducted, following the completion of the clinical study, we conducted finite element modeling to understand the biomechanics related to the prosthesis and to find mechanisms of the clinical findings. More recently, we use predictive modeling and artificial intelligence to improve the treatment predictions of these prostheses. Okay. This body of work has been a collaborative effort with the School of Aerospace Engineering, University of Sydney from 2008 until about middle of last year in 2024 when we published our last work on predictive modeling. Professor Emeritus Michael Swain was my main supervisor for the project. He worked in both, he's a physicist. He worked in both the School of Engineering and the Faculty of Dentistry, teaching biomaterial sciences to dental students. So he understood both engineering and dentistry, so he was able to bridge the gap between our fields, and he made communication easier between myself and the So he made communication easier between myself and the engineers. So his support was key to the project success, and which leads to many high-impact publications. Professor Chin Lee was my co-supervisor, and he guided me with patience, kindness, and understanding as I learned the biomechanics of implant prosthesis. Dr. Juning Chen and Jane Zong were also PhD students of Chin Lee and Mike Swain, and they were incredibly helpful in working with me with the finite element analysis to try to support and substantiate my clinical findings. So this professorial lecture and the professorial book are based on the key findings of these 17 years of research. Okay, so before I start with my lecture, I would like to take this opportunity to express my deepest gratitude, first and foremost to University of Technology Mara for providing the scholarship for my PhD study at the University of Sydney. I would also like to acknowledge the research findings that supported this work, which I received from the Australia-Malaysia Institute, from the Ministry of Science and Technology through the eScience grant, from the Ministry of Higher Education through the ERDS and FRDS grant. I would also like to thank the founding dean, Professor Datuk Dr. Muhammad Ibrahim Abu Hassan, for supporting this project. I am immensely grateful to our DSA, Puan Rohaya Rahman, for assisting me with all the clinical procedures and managing the various patients' appointment and recall visits for a period of about 8 years. I'm also thankful to our dental technologist, Encik Kamaruddin, who is now retired, for making all the procedures for me as I wanted to ensure standardization of the prosthesis. And last but not least, I would like to thank all the patients involved in the clinical study, who were mostly parents of the UITM staff and the USM Kubang Kerian. Most of these elderly patients have since passed away, and I pray that Allah will repay them generously in the hereafter for their contribution to science. In this lecture, I will first give an overview of the bone remodeling dynamics of residual ridge. This will be followed by the internal dynamics that influence bone remodeling, namely the hydrostatic pressure and mucosa deformation. This will be followed by the clinical factors affecting bone resorption. And finally, I would like to talk about the predictive modeling that we have developed for bone remodeling. Okay, let us start with the bone remodeling dynamics. Once becoming edentulous, once all the teeth are gone, the mandible and maxillary bone undergoes progressive resorption. It is a continuous process that lasts throughout life because of lack of stimulus to the bone as a result of tooth loss. This progressive resorption can also be referred as the catabolic resorption or baseline resorption, or also known as disuse atrophy. This progressive resorption is affected by anatomic, metabolic, functional, and prosthetic factors. The anatomic factors, like the patient's geomorphology, and the metabolic factors, such as the patient age, diseases, or hormonal status, is beyond our control. But the functional and prosthetic factors are within the clinician control, and which we should take into account when providing prosthesis for the patient to make sure that our prosthesis do not cause severe bone resorption in the long run for the patient. So understanding this phenomena of resorption, this bone remodeling dynamics is important as it affects the long-term stability and success of the prosthesis that we give to the patient. To understand the bone remodeling dynamics of edentulous ridge, let us compare between the bite force distribution of the natural dentition with that of the denture teeth. In the natural dentition, the bite force is transmitted directly to the jawbone via the periodontal ligament. So the bite force stimulates the bone cells, the osteoclasts and osteoblasts within the periodontal ligament and the alveolar bone to form and resorb bone for bone maintenance, to maintain bone volume and density. So this continuous stimulus from the bite force help to preserve the bone structure and prevent bone resorption. In contrast, without teeth, as in this complete denture situation, the bite force is transmitted through the denture teeth to the alveolar bone through the mucosa, but the mucosa is not as efficient as the periodontal ligament in transmitting the forces to the bone. As a result of this lack of stimulus to the bone tends to resorb. So this phenomena is also called disuse atrophy, and it's very similar to an individual who use a wheelchair because they cannot walk. So this long-term use of the wheelchair, this long-term disuse of the leg will make the bone lose its mass, and the bone will become smaller. Yeah, so exactly the same thing. So a critical factor in influencing this bone remodeling under this denture is the interstitial fluid pressure or the hydrostatic pressure within the mucosa. It is the pressure exerted by the interstitial fluid within the mucosa to resist deformation when the patient bites on the denture. When the hydrostatic pressure inside the deformed mucosa gets too high, it can squeeze the tiny blood vessels, the capillaries inside the mucosa, and block the blood flow within the mucosa. So this happens when the hydrostatic pressure within the mucosa gets above the systolic blood pressure in the capillaries, which is about 140 millimeter mercury or 19 kilopascal. So blood flow disruption disturb the oxygen supply and nutrient exchange to the bone and can cause stress-induced inflammation leading to bone resorption. Theoretically, the higher the compressive pressure on the mucosa, the greater the mucosa deformation and the resultant hydrostatic pressure, and the greater would be the blood flow disruption. To best illustrate this blood flow disturbance, kenapa ya? Okay. Boleh lah. Letak kat tepi sana sikit lah. Okay. Okay, sorry for the interruption. Okay, to best illustrate this phenomenon of blood flow disruption, let us compare between the complete denture situation with that of the implant retained over denture because of their different degree of bite forces. For a patient without teeth in a complete denture situation, they tend to not to bite too hard, so the bite force is quite low. Because the complete dentures are sitting on the mucosa, so they cannot bite too hard, or otherwise they will feel painful because the mucosa will be compressed. And also, the complete dentures, because they are resting on mucosa, they are not very stable and not very retentive. So if they bite too hard, so they might just dislodge the denture. In contrast, for the implant retained overdenture patient, when we place 2 implants in the anterior part of the mandible, anterior part of the mouth, the denture will become more stable and more retentive, and the patient tend to bite harder. So we measured the patient's bite force by asking the patient to bite on a load cell that is connected to a data logger and to a computer. So we asked the patient to do this multiple times, and we calculated the average value of the bite force. And we found that the average bite force for a complete denture is about 76 Newton, and the average bite force for the implant retained overdenture is about 135 Newtons. So patients with implant retained overdenture can bite much harder than the complete denture, and the bite force is about double in magnitude. So what happened to the mucosa and the bone underneath the denture when subjected to the higher bite force? So to answer these questions, we conducted a clinical study where we provided new complete dentures for all the patients involved. And then we take a CBCT scan as a baseline level for the bone level, as baseline reference for the bone level. And then we place 2 dental implants for the implant retained overdenture group. So we placed 2 implants in the mandibular anterior region. And after 3 months of healing, we exposed the implants and we connected the abutments, and we converted the complete denture into an implant retained overdenture. And after 1 and 2 years, we repeated the CBCT scan because we want to measure the amount of resorption that has occurred. So this is how we quantify the bone resorption. We quantify it in 3D manner using the STL superimposition-based techniques in mimics. So we superimpose the models taken at 3 time points. The red model is the model that we calculated from the CBCT taken before treatment. The yellow model, is from the CBCT taken 1 year after treatment, and the green model at 2 years after treatment. So we superimpose the models in mimics, and we export it to trimetics to reveal the areas and pattern of bone resorption. So this is this image here illustrates one of the bone resorption pattern of one of our participants after she has worn the implant retained overdenture for about 2 years. If you look at the bone remodeling scale here, the red areas indicate bone resorption, and the white and green areas are bone deposition. For this particular patient, we can see a lot of red, meaning she has suffered a lot of bone resorption, and the deepest bone resorption that she had goes to about 2.5 millimeters in some areas. In coronal section, in this region, in the posterior part of the mandible, we can see the pattern of bone resorption. You can see here the red outline indicates the model before treatment, and the yellow outline is after 1 year. So the difference between the red outline and the yellow outline is how much bone resorption has occurred after a period of 1 year. So we can observe the same thing on the other side of the mouth. And if we look more anteriorly, in the closer to the canine area, so you can see, this is after 2 years. So you can see the green outline is after 2 years. So the distance or the gap between the yellow outline and green outline is much smaller. So it shows that resorption is most rapid during the first year, and it slows down in the second year. So the same thing can be observed more anteriorly, where you can see that the outline between the red and yellow is quite big, a lot of resorption, very rapid in the first year, but in the second year, the green outline is much closer to the yellow one, so much less resorption after the second year. So to measure the area of volume of bone resorption, this is how we do it. So we cut the region of interest, which is distal to the implant and up to the ascending ramus. And we converted this block of model into solid blocks. As you can see, the red is the pre-treatment model, and the yellow after 1 year. So you can see that the yellow model is quite small compared to the red models because resorption has occurred. So the program can automatically calculate the area and volume of bone resorption at each year. So the difference between the two would be how much bone resorption has occurred. So we can repeat the same procedures for the second year. Okay. So just to recap, so the implant retained overdenture exerted 135 Newton of force, which is about double that of a complete denture, and as a result has caused more bone resorption compared to the complete denture, which is also about double that of complete denture. So to understand the biomechanics of this prosthesis, why this happened, so we conducted 3D finite element analysis to simulate and substantiate our clinical findings. So we use the CBCT scan of a specific patient, and we model the complete denture and also the implant retained overdenture cases. So in this finite element analysis, we analyze the mucosa hydrostatic pressure as well as the mucosa deformation. So this is the result of the mucosa contact surface deformation. If you look at the scale here for the contact surface deformation, so the areas of blue, very little deformation, about 0.1, 0.2 millimeters. And as we go to the red areas indicate greater surface deformation, can go up to 1 millimeter or beyond. So for the complete denture patients, we can see that the mucosa contact surface deformation is fairly uniform. A lot of blue, that means minimal deformation, around average about 0.16 millimeter. And the deepest part goes to 0.58 millimeters. In contrast, if you look at the implant retained overdenture scenario, the mucosa deformation is much greater. You can see more red and yellow areas. And the deformation is only concentrated in the posterior region of the mandible. It's not uniform like the complete denture. It's concentrated in the posterior region, and there's almost like zero deformation in the anterior region where the implants are placed. Maybe you will say this is expected because greater pressure will deform the mucosa more. But what if we increase the bite force of the complete denture? If we increase the bite force of the complete denture to 135 Newton, which is similar to the implant retained overdenture, we can see that the mucosa deformation still retains fairly uniform. Although there's like some increase in the mucosa deformation, but it's still uniform. It's not concentrated like in the implant retained overdenture, which is very damaging. So there are three possible reasons for this. Why in the complete denture, the deformation is fairly uniform and low in magnitude? Because number one, for the complete denture, it has a large denture-bearing area to support the denture. In comparison to the implant retained overdenture, the posterior support in the here is much smaller. Okay, so the posterior part of the implant retained overdenture acts like a cantilever. Okay, and the second reason, for the complete denture, it can move about during use. It's not fixed. But for the implant retained denture, it is rather fixed in nature. So because of that, it always hit the same consistent point every time. So that's why causing a lot of bone resorption. And the third reason, the complete denture, it can flex a little bit, so it can absorb some of the bite force. But for the implant retained overdenture, it's more rigid, so it will transfer more force to the mucosa. Let us then look at hydrostatic stress. So this is how we measure it. So we use a Fortran subroutine in the Bakers, and it was determined by the 1/3 of the sum of these principal stresses. And this is the result of the hydrostatic pressure. So as we can see, in the complete denture, okay, the hydrostatic pressure, again, is fairly uniform and also low in magnitude. As you can see here, it's like within this region, you see the yellow, the greenish color. But for the implant written over denture, the hydrostatic pressure is mostly concentrated in the posterior region, and is much higher in density, much higher in magnitude. So it is about 36 to 40 kilopascal. So if we compare the hydrostatic pressure with the mucosa deformation, we can see that the pattern matches. For the complete denture, the fairly uniform hydrostatic stress and fairly low in magnitude corresponds to the fairly uniform mucosa deformation in the complete denture. And for the implant written over denture, again, we can see the concentrated hydrostatic pressure cause more mucosa deformation in the posterior region. And if we compare, we try to correlate with bone resorption, we can see that greater surface deformation, greater hydrostatic pressure result in greater surface deformation, which in turn cause more bone resorption in the mandible compared to the complete denture. So to recap, the implant written over denture, which exert twice the force of the complete denture, cause greater surface deformation, about twice that of complete denture, which in turn cause greater hydrostatic pressure, and which subsequently cause more bone resorption in the implant written over denture patient compared to the complete denture situation. So to further assess the cushioning role of the mucosa, the absorption of the strain energy density in mucosa was used to measure the severity of the compression-induced disturbance. The total strain energy density was calculated by summing up the stress-strain products across all mucosal elements under stress. So the strain energy density absorbed by the mucosa in the complete denture situation, we can see that almost 95% of the strain energy density is absorbed by the mucosa, meaning the mucosa underneath the complete denture can absorb a lot of the force. In comparison to the implant written over denture, only about 75% of the force is absorbed by the mucosa, so it is much less efficient. So we have seen how the hydrostatic pressure correspond with the contact surface deformation in terms of the intensity and the bone resorption that it causes. So is it true that can we substantiate this finite element modeling? Okay, so we measure blood flow measurement in the patient. So we use laser Doppler fluorometry to measure the blood flow returned to the mucosa. So we call the patient in, and then we ask the patient to remove the denture. So we measure the blood flow return every half an hour for a period of 2 hours. So the initial blood flow under the implant written over denture was significantly lower than in the complete denture group, and the blood flow disturbance was found to be significantly correlated with bone resorption. So having seen that how the bite force affects the internal dynamics of bone remodeling and affects the bone resorption, so we now have to think of external factors that can affect this bite force. So logically, it's a muscle strength. So the greater the power of the muscle, the stronger the muscle, the higher would be the bite force. So what would influence this muscle strength? So one of the factors that influence muscle strength is the geomorphology. So we then proceeded to investigate the effect of this mandibular morphology on bone resorption. So we investigated several parameters, several dimensions of the mandibular bone. So we investigated the ramus length, ramus width, the corpus length and corpus height, as well as the gonial angle, which is the angle of the mandible, corner of the mandible. So we found that only the gonial angle, which is the angle of the mandible, significantly influences the bone resorption. The other dimensions of the mandible does not play any significant role. So when we compare the gonial angles with the bone resorption, we found that patients with a low gonial angle suffered more bone resorption compared to the patient with a high gonial angle. So we can see a lot of reds here indicates resorption. So patients with a low gonial angle, smaller gonial angle, will experience a lot of bone resorption, and patients with a high gonial angle suffered minimal bone resorption. So this is because in the low gonial angle patients, the masseter is positioned more vertically and it is more perpendicular to the occlusal plane. So that's why it kind of intensifies the hydrostatic pressure and the mucosa deformation, leading to higher bone resorption. For the large gonial angle patients, the muscles is like more longitudinal, it's more parallel to the occlusal plane, so the white force is much smaller, and when it also directs the denture to move forward, causing more bone resorption in the anterior part of the mandible rather than in the posterior part. Okay. But not all of our patients experience this. Not all patients with a high gonial angle get a lot of bone resorption. So we suspect there's something else. So this is not the complete story. So we suspect maybe the mucosa actually plays a protective role in these low gonial angle patients. So we then proceeded to investigate the effect of the mucosa thickness on bone resorption. So we quantified the mucosa thickness in three-dimensional manner using the patient's CBCT with a barium sulfate denture in place so that we can delineate the mucosa thickness clearly. So this is the segmented mucosa, and this is the color maps of the mucosa revealing the various range of thickness. And then we correlate the mucosa thickness and bone resorption, and we found that where the mucosa is thin, there is a lot of bone resorption, and where the mucosa is thick, there is much less bone resorption. So there is an inverse relationship between the mucosa thickness and bone resorption. So this slide illustrates the scenario for the other 6 patients that we have investigated. So basically we can see where there is a lot of red on the bone, which means a lot of bone resorption, it corresponds to thicker mucosa, which is also color-coded green, right, in this case. So where you see a lot of green, that's corresponding green, that means minimal bone resorption when the mucosa is thick, and a lot of bone resorption when the mucosa is thin. Thin means the mucosa is 1.5 millimeter thickness and below. So it seems that mucosa thickness of at least 2 millimeter is protective of bone resorption. So what are the clinical implications? Patients with smaller gonial angles and thin mucosa, less than 2 millimeter, are at greater risk of developing bone resorption. So what are the strategies that we can take to minimize this bone resorption? So perhaps in an implant retained overdenture patient, instead of just putting 2 implants in the anterior part of the mandible, we can also place short implants in the posterior mandible just to prevent the load on the mucosa in the posterior part. Also, we have to make sure that when we take impression for the patient, we want to capture all the danger-bearing areas because we want to distribute the force over a big area to minimize the force on the mucosa. And also, we must make sure that we give the patient occlusal balance to try to distribute the force over a bigger area. So finally, I would like to talk about the predictive model that we have developed for bone remodeling. So this predictive modeling can help us to forecast bone resorption for a specific patient. Okay, so we integrate the mucosa hydrostatic pressure and mucosa deformation into the system so that we can predict how likely the bone will remodel over time. So to do this in silico computational framework, a computer-based method to analyze changes in the jawbone over time. So there were 4 key processes to achieve this. So first we did data processing where we extract CBCT images from the real patient and we use the tomographic geometry stimuli analysis to segment and track changes in the jawbone over time. And then we conducted finite element analysis. We use abacus based on a specific patient to analyze the hydrostatic pressure in the mucosa and strain energy density in the bone. And then we do machine learning analysis. We use self-organizing maps to identify patterns in bone loss and helps determine which factors contribute most to bone resorption. And then a governing equation for bone resorption driven by hydrostatic stress was then developed using power law modeling. Finally, we do the simulation. We integrate everything into the Python abacus simulation to predict future bone loss based on the governing equation. So this is the governing equation that we have developed. So briefly, delta D represents the change in residual ridge height or the bone resorption. So the negative value indicates bone loss. And this part of the equation here, it denotes the average hydrostatic stress in the mucosa. And C, it represents the baseline resorption independent of stress, and it accounts for intrinsic or age-related bone loss not driven by mechanical stimuli. So if the hydrostatic pressure is less than 0, there is no bone resorption. But if the hydrostatic pressure is greater than 0, then there is bone resorption, and we use the second expression to calculate the bone loss. So the predictive model demonstrated a reasonable accuracy with an R value of 0.62, indicating a good correlation between the simulated bone resorption and the clinical measurements. So you can see here, this is our clinical resorption, and this is the simulation. It's fairly close. And if we tabulated the amount of bone resorption that has occurred, so you can see the clinical and the predicted differs by only about 5%. So when you correlate between hydrostatic stress and resorption, the hydrostatic stress is significant biomechanical stimulus driving resorption, particularly in the first year post-treatment. However, this correlation diminished after the first year, suggesting that soft tissue-driven resorption is time-sensitive and primarily active during the initial adaptation period. So strain energy density showed a weaker correlation compared to the hydrostatic pressure, and indicates that bone resorption was less influenced by direct mechanical loading on the bone than hydrostatic stress in the mucosa. So there is also a temporal trend in this correlation. During the first year, bone resorption is mainly driven by hydrostatic stress, leading to rapid bone loss. But after the first year, the process stabilizes with age-related bone loss becoming more dominant. This finding highlights why early adaptation strategies such as optimized denture design are essential. So what are the clinical significance? So most resorption occurs during the first year due to the increased hydrostatic stress in the deformed mucosa. As the residual ridge try to conform to the contour of the new denture's fitting surface. This is called the denture settling effect. So denture settling effect occurs during the first year. So most bone resorption occurs during this time period. But the influence of this hydrostatic stress diminishes over time as the residual ridge adapts to the denture, reducing the rate of bone resorption during the subsequent years. So we saw that in our clinical study earlier. And to minimize the need for significant adaptation, accurate fitting of a new dentures to the residual ridge is essential. And reducing the denture settling effect helps reduce early bone resorption and promotes long-term prosthetic stability. So what are the strategies to reduce this hydrostatic pressure? So number one, gradual transition to implant routine overdenture. So we should delay the conversion from the complete denture to implant routine overdenture to allow the denture settling effect to take place under smaller biting loads. This gradual transition helps reduce mucosal stress and reduce early bone resorption. Second, we should do a proper chest side pickup technique of the implant abutments into the fitting surface of the denture. So during the chest side pickup of the male or female components of the abutments, we have to ensure that the denture is fully seated on the mucosa in its original position, because any misalignment can disrupt the denture-mucosa relationship, requiring further adaptation and potentially increasing the stress on the mucosa and the bone. Number three, we should limit frequent denture remakes. Avoid remaking dentures too frequently, because as repeated adjustment force the residual ridge to continuously adapt, so increasing the stress-induced bone resorption. So the more dentures we give to the patients, the more the patients has to adapt to new dentures, and the process will just cause a lot of bone resorption. So we should also minimize mucosal compression during impression. When we take impression, we shouldn't compress too much on the mucosa because we want to make sure we capture the mucosa in its resting state. Okay? So prevent excessive mucosal compression during the impression process to ensure the denture rests on a stable and uncompromised tissue base. And finally, we can also use soft liner. So the use of soft liner underneath the denture can also help to reduce some of this hydrostatic stress. So to conclude, so these are the conclusions based on the 17 years of research. So number one, related to the hydrostatic stress and bone resorption. Hydrostatic stress in the mucosa is the primary driver of residual ridge resorption during the critical first year post-treatment. And early resorption diminishes over time as the residual ridge adapts to the prosthesis. The clinical relevance, accurate denture fit and proper prosthetic design are essential to minimize hydrostatic pressure and stress-induced bone resorption. Strategies such as gradual load introduction and careful impression techniques can enhance long-term outcomes of our prosthesis. And as for prosthetic recommendation, gradual transition from complete dentures to implant retained overdentures is required. We should also minimize frequent denture remakes and avoid over-compression of the mucosa. And for the future implications, advanced modeling and simulation techniques can further refine prosthetic designs, and individualized treatment planning remains key to reducing bone resorption and also improving prosthetic longevity. Thank you very much for your kind attention.
Ribuan terima kasih diucapkan kepada Profesor Dr. Rohana Ahmad atas perkongsian ilmu yang sangat mahal nilainya buat kita semua. Mohon Profesor Dr. Rohana Ahmad untuk kekal berada di atas pentas untuk acara seterusnya. Sebagai tanda penghargaan dan ingatan, dengan ini majlis menjemput Yang Berusaha Profesor Madya Dr. Muhammad Haizat Abu Manaf diiringi oleh Yang Berusaha Profesor Madya Dr. Masurialis Ahmad dan Ketua Pusat Pengajian Pergigian Restoratif Dr. Tengku Fazrina Tengku Muhammad Arif untuk naik ke pentas bagi menyampaikan cenderahati ikhlas daripada Pusat Pengajian Pergigian Restoratif Fakulti Pergigian UiTM. Dipersilakan. Kuning emas masaknya padi, penuh kepuk hasil tampian. Terima kasih daun keladi, budi tuan-puan jadi kenangan. Andai ada sumur di ladang, boleh saya menumpang mandi. Andai ada umur yang panjang, boleh kita berjumpa lagi. Jawatan Kuasa Penganjur merakamkan ucapan penghargaan dan terima kasih kepada div-div kehormat dan para tetamu atas kesudian hadir memeriahkan majlis pada hari ini. Tidak lupa juga kepada semua pihak yang telah memberikan sumbangan dan kerjasama dalam menjayakan majlis ini. Saya bagi pihak Jawatan Kuasa Majlis Syarahan Profesor Fakulti Pergigian UiTM memohon 1000 kemaafan atas sebarang kekurangan semasa majlis ini berlangsung. Sebelum berpisah, ayuh kita abadikan detik bersejarah pada pagi ini dalam satu sesi fotografi. Dengan ini dimohon para hadirin untuk bergerak ke bahagian tengah auditorium dan untuk rakaman gambar bersama Profesor Dr. Rohana dan Div-Div Kehormat. Dipersilakan. Okey, ready? 1, 2 dan 3. Okey, lagi sekali. 1, 2, 3. Sekian sahaja Majlis Syarahan Profesor UiTM, Profesor Dr. Rohana Ahmad. Untuk itu, Majlis menjemput Profesor Dr. Rohana Ahmad bersama-sama Div Kehormat ke Dewan Al-Jabar bagi jamuan makan tengah hari. Sehingga kita bertemu lagi di lain masa. Sekian, wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
UiTM.